Welcome everyone to our MedStar Emergency Physicians pop-up learning session. Today's date is April 24th, 2020, and this is our next in the installment of series on COVID-19 updates. And we're very pleased to have Dr. Manish Goyal from emergency medicine and part of our EM critical care medicine section in MedStar Emergency Physicians, who's going to present and talk with us for about 10 or 15 minutes regarding out-of-hospital cardiac arrest, Lucas, vent settings, early termination. Then we're going to have a 30-minute or so moderated Q&A panel discussion led by several of our EM critical care specialists. Manish will join that panel along with Dr. Shane Kapler, Dr. Rory Spiegel, Dr. Jennifer Yu. We also have Dr. Carrie Lehman, who's with us as well, who always provides great insights and commentary. So welcome to everyone. We may have a few others. Janice Lamar is supposed to join us as well. Hopefully she will be able to, but we'll go ahead and get started, and I'll turn it over to you, Manish.
Great. Thanks, John. Nice to see you all. These are really stressful times. I hope that all of you are doing well. We'll spend the next 10 minutes or so going through these MedStar Emergency Physicians cardiac arrest guidelines. Just to start, as we go through these, first, I want to encourage you to print this out and review this with your team at your next huddle, because a lot of this is suitable for pre-planning before your next code comes in. As we start at the top, even though we think that most of these patients, when they come in, are going to come in PEA arrest from hypoxemia, they can also come in VFib and VTAC. So every out-of-hospital cardiac arrest should be considered a PUI. And unfortunately, regardless of what we do, we think that most of these patients are not going to do well if they're coming in coding. When we look back at our own data at the hospital center, and these are 4 years of consecutive out-of-hospital cardiac arrest from the pre-COVID era, what we see is we have roughly 100 codes or so per year that come in. The vast majority of these patients don't get return to spontaneous circulation. A smaller segment go on to get admitted to the ICU, and even fewer survive to hospital discharge. Again, pre-COVID era, about a 2.7% survival to discharge. If we break that down a little bit further and look specifically at the group of patients that come in with a non-shockable initial rhythm and no pulse on ED arrival, so this is the individual whose EMS's first rhythm was PEA or asystole, they make it into the hospital but no pulse on arrival, none of those patients survived over 4 years. And I think that this is important information, because when we're seeing these patients come into the hospital in cardiac arrest, what I'd encourage you to do is very quickly, just based on what was the initial rhythm, do they have a pulse in front of you when they get there, categorize these individuals as salvageable versus non-salvageable. And part of the reason I think that's so important is if you very quickly categorize someone as non-salvageable, it may change your treatment algorithm to potentially pronouncing earlier, potentially leaving the patients on EMS's monitor so you don't have to switch over to ours and consume those resources. If EMS has already placed an airway, be it a supraglottic airway or an ET tube, oftentimes they're coming in with end-tidal CO2 already in place, using that to confirm placement and not having to replace the airway. Many of these patients are coming in with the Lucas device already, keeping that in place as well. So with the understanding that you're probably going to pronounce these patients pretty quickly, I think it's reasonable to consider leaving the patient on all of that for those first few minutes of resuscitation. As we go through the algorithm here, first and foremost, minimize the number of people that are in the room. We want to minimize our staffing to just the minimum amount that we need. Ideally, placing these patients into negative pressure rooms. When we move on to the equipment, we're going to attach a virus filter onto the ambu bag, ideally before the patient gets there and before any bagging. We want to establish a warm zone with a Mayo stand or a cart right inside the door where equipment can be handed off as need be. You want to leave the code cart outside of the room. Again, hopefully, if this is a non-salvageable patient, you're just going to leave the defibrillator on the patient that came in with EMS. If you think it's going to be a longer code, then bring in just the defibrillator from the code cart, so all of that doesn't have to be cleaned after the process. And then you're going to want to use a Lucas device. I think it's fantastic that we all now have Lucas devices in all of our MedStar emergency physicians EDs. If you haven't use the device, watch the video. It's a 6-minute video. It goes over how to use the device very nicely, and I think answers most questions. But as you become more familiar with this device, know that a Lucas device is not titratable. It has a set heart rate of just about 100. It has a set depth of 2.1 inches. The one thing that you can do to potentially alter cardiac output is change where that plunger sits. But know that that's also part of the downside of the device, is that if you're not watching it, it can slide inferiorly or caudally, and it can cause intra-abdominal injury if you're not paying attention to where that plunger sits. So you want to kind of keep an eye on that, particularly for one of those prolonged codes. As we move on down to the actual ACLS, not a lot different, although, just like in any code, you're going to want to try to deliver a shock quickly if somebody's in VFib or VTAC. If they're not in VFib, VTAC, you're going to want to prioritize putting in a definitive airway, again, with that viral filter. One other subtle change there is you'll stop compressions when doing intubation. And then another reminder, again, about the relative futility of that patient population that comes in non-shockable, no pulse on arrival. One of the other bigger changes, and some of you may already be doing this, is using the ventilator during cardiac arrest. And this is something I think to consider either for the patient who has a prolonged code or codes in the emergency department after they're already on the vent. And if you're going to do this, I'd recommend using these specific settings. And so that's going to be assist control or volume control mode of ventilation, a tidal volume to 400 or 500 in that vicinity, a rate of 100, a rate of 10, an FiO2 of 100%, and a PEEP of 0. And what that's going to do is minimize intrathoracic pressure to allow preload and therefore increase your coronary perfusion pressure. The other two big changes, the first is sensitivity. And when you have somebody that's in assist control or volume control, the vent is looking to see if the patient wants another breath. It's trying to sense that. And the way that it senses that is it senses either a pressure drop in the circuit, or it senses flow that seems to be coming, it's a demand for flow that's coming from the patient. And so that's called the sensitivity or the trigger. And you see that here. This is the interface that you would see with a Puritan Bennett 840 ventilator. So maybe a little bit different depending on the type of ventilator that you're using. This currently is set, the way that's described here is based on pressure, and that is negative pressure that the patient's generating. It's generally set on most of our patients somewhere around 2 to 3 centimeters of water. That is, that the patient would have to generate 2 to 3 centimeters of water of negative pressure for the vent to sense that it wants a breath. If you leave it on that and the patient's getting chest compressions, as the device releases or as you release, it creates some negative inspiratory force and pressure that may cause the vent to trigger. Therefore, you want to put that sensitivity as high as possible. In this case, on our vents, it's 20 centimeters of water, and that's to minimize any additional breaths above the 10 that we're already delivering. The one other thing we want to change is the alarm setup here. And alarm is a little bit of a misnomer. It's much more than an alarm. The specific alarm is the peak pressure alarm. And the way these vents are usually set, our RTs usually set a peak pressure of 45. And what that means is that if the vent is sensing a peak pressure of 45, it's going to alarm, and more importantly, it's going to stop flow. So it's not going to deliver the remainder of that breath. And as you're doing chest compressions on patient, it's very easy to hit a peak pressure of 45. So you want to change this to as high as it will go, which again, our vents will allow it to go up to 100. So these are the settings that we'd recommend. Again, the big ones here, changing the sensitivity to 20 and the peak pressure to 100. So just to kind of refresh here, we want to try to quickly categorize people as salvageable versus non-salvageable. If non-salvageable, consider the risks and benefits of prolonged resuscitation efforts. Consider that even before COVID, most of these patients don't go on to survive. And if you do categorize somebody as non-salvageable, consider using as much of EMS's resources that they've already consumed so that we're not having to use our own and switch people over. Every code is a PUI, and you want to minimize your staff beforehand, and ideally, again, define this before the patient comes in. We want to use a viral filter on every ambu bag. We want to establish a warm zone. We want to use the Lucas device, either EMS's if they've already on one, or our own. And you want to consider using the vent for the longer codes. And with that, John, happy to take any questions.
It's great, Manish. Thanks so much. And so a couple of points to emphasize and underscore. First and foremost, that, and Manish, correct me if I'm wrong, even in the pre-COVID circumstance of having no pulse, not shockable, the survival essentially is zero in the cohort of patients that we have pre-COVID from MWHC, correct?
That's correct.
And so our algorithm has been updated just recently. That's the one that Manish was just going over, and it's posted to our COVID resources page. It was also sent via email to our whole group yesterday. And so we'll use this as a launch point to open up our panel. And I do want to introduce, as I mentioned, Jennifer Yu, Carrie Lehman, Shane Kapler, and Rory Spiegel. And if you could turn on your video if you have capability, just so folks can see you. Welcome to the panel, and thanks for participating. We have a couple of different topics that we want to cover. In the first bucket, the first bin, is cardiac arrest. And I think one of the issues, and we've covered this in prior MEP pop-up learnings, is really avoiding and minimizing spray in this aerosol generating procedure. Not only the active intubating, but also obviously bag valve mask or supraglottic device use, as well as CPR and sort of all of the chaos that typically happens in a controlled fashion during a resuscitation. And so we've talked about viral filters. We've talked about the possibility of LMA, PEEP valves, and then pre-oxygenating with BiPAP. So any new pearls or things that have been learned from the ICU setting, from the ED setting for any of our panelists that we should be employing or not be doing on a regular basis. One example is we've talked about the pearls and the pitfalls of pre-oxygenation by utilizing BiPAP through a ventilator potentially or not. Are these the type of things that we should be using? A lot of our patients are coming in very hypoxic. They need to be intubated, but how do we optimize prior to intubation and make sure that we're keeping our patients safe and keeping our associates and our staff safe as well?
John, are you talking about in cardiac arrest or just in general?
So I would say we can start with cardiac arrest, but also in general, just extrapolate it to general as well.
So I guess I can start. If you look at most of the data, and there's not a lot, but most of the data shows that your biggest risk around cardiac arrest is not surprisingly managing the airway. And so you want to limit your exposure there as much as you can. And so I think the biggest thing you can do is like when you said, is just basically identify the patients that have no actual chance of survival and limiting any kind of airway exposure in those patients. Once you get past that, I mean, you can just think about it. If they come in with an LMA in, just keep that LMA in as long as you're getting a good waveform and title, so you limit the amount of trade-offs you're doing during the cardiac arrest. If you get ROSC, you can then switch it out to a definitive airway after. And I think the other thing to think about is in the patients that have VFib, shockable rhythm, who arrest in front of you essentially are really the only ones you're going to see with that, because most of the ones who had shockable rhythms in the field either got ROSC by the time they've reached you. But if they have a cardiac arrest in front of you and it's a shockable rhythm and they don't have an airway in at this point, you really can ignore the airway for the first few minutes. So simply putting some oxygen, a non-rebreather on them, and let them passively have oxygen down its concentration gradient and focus on CPR and defibrillation during those first 2 to 3 rounds will also limit your exposure during that period.
And John, it's worth mentioning. At some point in time, I think that somebody might have recommended a PEEP valve, and I just want to be clear that intra-arrest, I don't think we should be using PEEP valves. Because intra-arrest, we want to minimize intrathoracic pressure to allow blood flow to return to the thorax.
Great. Additional thoughts, specifically with the setting of cardiac arrest, things that we can utilize to, keep again our patients and our staff safe. the viral filters early and frequent if they're available, to make sure we have those in the circuit. And any comments regarding pre-oxygenation, kind of optimizing intubation conditions?
Yeah, so 2 points there. The first one thing that I've noticed with our EMS colleagues when they bring patients in is they don't always have a viral filter on. So as much as I would say, use the equipment that they've already brought them in, particularly if you're seeing somebody who's non-shockable, no pulse on arrival, the only thing that I would change is the ambu bag and the filter. I'd leave their Untitled CO2 in place. I would use their monitor. I would use their pads. I would use their Lucas device. There's no reason to switch all of that stuff off, because I'm going to pronounce that patient within 10 minutes, unless something turns around, in which case we can switch all of that. But more often than not, at least what I've seen, is they don't have a viral filter on it. I think that that's an important piece to include. Now, the pre-oxygenating piece, I think that BiPAP works very well for these patients. And so for all of these patients that I'm intubating, I'm using ketamine and succinylcholine, and doing that, kind of for very specific reasons. But the beauty of the ketamine, when you take that in, you have that with you. One of the advantages is if the patient's not tolerating BiPAP, I give them 50 of ketamine, because they come in the 50 milligram syringes. I give them 50 of ketamine, and it works great. And you dissociate them, and then you can pre-oxygenate them for a few minutes before putting them down. So I think that BiPAP works great for these patients to get their PaO2 up high pre-intubation.
Great. Additional thoughts from anyone else on the panel?
No, I think BiPAP is also probably your best bet. And we can probably talk about later. I think it's mostly you're just able to deliver the highest concentration of FiO2 without entraining any room air when you hook them up to that circuit.
Well, and Rory, it's worth expanding on that, because you don't need high settings. You need 100% FiO2, but you don't need, I don't think you need very high PEEP, and you don't need very high inspiratory pressure. And so, we talked in the past about vent-based BiPAP. Those two numbers are separate but additive. That is, we set a PEEP and we set a driving pressure on top of that. You don't need very high driving pressures. And the downside of the higher driving pressures, particularly with the non-vented masks, those don't have as good of a seal. As you get into higher pressures, you're just going to create more leak.
Yeah, no, I agree. I don't even know if you need much CPAP. This disease process we're seeing more and more is less of an overall de-recruitment and other reasons for hypoxemia. And I think what the BiPAP circuit is doing is simply delivering 100% FiO2 at very high flow rates that can keep up with these patients' inspiratory drive. And so you can probably get by with a CPAP of 10, and you'll pre-oxygenate most of these patients quite fine and avoiding that kind of leak.
Yeah, I mean, I agree with that. I don't even think I would be using BiPAP. I mean, I would just be using CPAP settings, because it's purely just delivering some oxygen. And you could start at a lower setting and just see if you can get there with that. And if not, you could titrate up a little bit. I will say that, from experience in the broader community, you have to be very wary of just trying to throw a tube into these people without optimizing them, because they will they will code on you after intubation. So there is a little bit of stuff that's like in the Twitter sphere that's talking about, these patients tolerate the hypoxemia really well, all that. I think that's probably true on people who are not in distress. When you're in respiratory distress and you're hypoxemic and you don't optimize them, they will arrest. So I think it's very vital that you have to do your pre-oxygenation thoughtfully.
Yeah, and I think there's a misinterpretation of what's happening on the Twitter sphere, that they tolerate hypoxemia, but when you take away that respiratory drive and paralyze them, they will desaturate very, very quickly. They are very oxygen dependent, and when they get really sick, and even when the oxygen falls off, they will code on you quite quickly. But the good news is typically you have some time to kind of pre-oxygenate these patients. They don't have severe respiratory fatigue, and their diaphragm works, and the compliance of their lungs is relatively normal. So you have some time to put them on CPAP and actually give them time to pre-oxygenate.
So great discussion. And getting back to that second point, we were talking about cardiac arrest, and now let's kind of flip to the other side and just talk about O2 management options, kind of the spectrum from nasal cannula to non-rebreather to high flow to PAP to vent if you go ahead and intubate. And getting to some of the lessons learned from the trenches, not only what you're seeing in the units and in the EDs, but also the folks that we admit to the floor perhaps, and they rapidly find themselves in the IMC or the ICU, and what lessons we can take from that and learn from that in terms of our practice in the emergency department setting, when to pull that trigger and go from nasal cannula, non-rebreather, when to try high flow, and what are some of the criteria that we can utilize to make those decisions prospectively in our patients.
So, there's a lot being kind of discussed on what the actually underlying physiology of this disease process is. And we don't have to get into that. I don't think we actually know, but the phenotype that presents is essentially this one that seems pretty one of a pure hypoxemia, meaning most of the time when you encounter patients with respiratory distress, in the emergency department, it's a mixed picture. So they have hypoxemia, but they also have a decrease in their compliance from a pneumonia or edema or so forth in their lungs. And they have some VQ mismatching, so they're having trouble ventilating as well. And that's typically when you see patients in this traditional respiratory distress where, a SAT of 82, they will not look very comfortable. A lot of these patients have a much more isolated disease process where they will purely be hypoxemic, but are managing their ventilatory requirements quite well. And so the way I think about it is a disease where you are trying to give them enough oxygen for them to be okay. And you are basically titrating up the amount of oxygen you can give someone, starting with a nasal cannula to a non-rebreather to high flow nasal cannula to eventually a non-invasive circuit. And, in other disease processes, there's a lot of nuances and complicated kind of differences with those different tools. In this case, it's simply you're being able to deliver more oxygen, because what happens is as you're breathing, you entrain a lot of room air. And so tools like a nasal cannula, a standard nasal cannula, or a non-rebreather basically can't keep up with the patient's inspiratory flow rates, and you would end up entraining a lot of room air, and so you don't get that high a concentration of FiO2. When you add a high-flow nasal cannula, and then a high-flow nasal cannula with a non-rebreather over it, and then eventually a non-invasive circuit, what you are doing is able to deliver them 100% FiO2.
John, I think too, one of the things that we've seen is that you have to have a combination of looking at the oxygen saturation as well as the work of breathing. Because of what Rory said, there's different phenotypes, and you need to use both of those things to decide when you need to escalate your level of oxygenation.
And I just want to just when we say work of breathing, it's not just respiratory rate. These patients will actually breathe really fast, but because of their compliance of their lung is typically normal, they can breathe very fast for infinity. There's actually a lot of good physiological studies before the COVID time that show that people can breathe in the 30s and 40s as long as they have normal compliant lungs without getting any fatigue. And so when we mean respiratory distress, it's actually looking like they're working to breathe. So they have inspiratory muscle fatigue, they're using accessory muscles, so on and so forth.
So predictors for success on high flow. I know it's been tried. We've utilized it a lot in the ED setting. Oftentimes it works. A few times it doesn't. What have you seen from looking at it from an ICU perspective? I'll start with you, Jen, if you wouldn't mind unmuting and giving us your thoughts about high flow and the predictors of success, and when folks have found their way to the ICU when high flow has not been successful. What can we learn from those patients?
Sure. Thanks, John. So in my experience over the last couple of weeks of seeing these patients, they can quickly flip actually from the phenotype that Rory explained of having a very good compliance to quickly not being compliant. And so I think it's really about the assessment of the patient and how they look. So when I see patients bounce from the floor to the ICU or they start to worsen while they're in the ICU, it's generally from kind of they're switching those phenotypes, and so they're becoming more and more poorly compliant. Sorry, let's see. Poorly compliant, and then also kind of not getting the assessments on the floor. We're seeing some of the patients, unfortunately, maybe that they're decompensating on the floor because they were just left for 4 to 8 hours without a provider reassessing kind of where they're at. So from my perspective, I'd rather see that a patient has kind of goals of discussion, kind of care, goals of care discussions early, and early intubation if they look like they're on the trajectory to becoming poorly compliant and having increased respiratory distress.
So some of the other prior conversations we've had have focused on, there were two different schools of thought. We kind of started our trajectory about a month ago with early intubation, intubate early. Then we went through a phase of, well, maybe we should try other things because we know these patients are going to be sick for up to 2 weeks, 14-day period or so. So maybe if we can buy some time on PAP and not ventilator time, that could sort of shorten the duration of the need for ventilator care, ventilator-driven care to support. What are the current thoughts? Like, what are you thinking about? Shane, when you're taking care of patients in the unit now and in more recent weeks, which strategy are you employing?
You know, I mean, the thing is, I don't think we really know. We still don't understand this disease. Anybody who says that they do, even the H and L phenotype stuff, you know, I mean, it does seem to fit with clinical experience, but you know, who knows? We could look back on this and say that potentially wasn't the correct approach either. So, you know, I think you gotta approach this disease with a lot of humility and understanding that we don't really know what's going on with it, and we're sort of learning as we go. And I think we're going to look back on this for years and sort of sort out what this process was and what the physiology was underneath. So I approach everything like that I, first of all, don't really know. You know, so I'm going into everything, and what you got to rely on is basically the tools that we have, which is our clinical acumen and our understanding of the physiology of the best that we can understand it. And so, and then the experience we have. Some of the experience we know is when we intubate these patients, the likelihood of the mortality skyrockets, and the likelihood of their multi-organ failure skyrockets. Now, is that just because we're catching them at the edge of the cliff and the intubation is more of a surrogate, or is the mechanical ventilation driving some of that signal? I don't know what the answer is. I'm not really sure anyone does. What I try and do is, I mean, I also look at we have you know, limited resources in terms of staff and supplies, and so I try and be a steward for that. So I think if someone doesn't have a physiological need for a ventilator, I don't think the early intubation idea makes any sense. That's just me. I think that was a little bit when we were thinking that this pandemic might be a little bit more limited, and if we were dealing with like we were with viral hemorrhagic fever, like Ebola type patients where we had a handful of them, sure, let's intubate them because we can control, you know, sort of the exposure, aerosolization long term. But we're obviously well beyond that point. So I think at this point, you just have to look at physiologically. I trial them. Most of the people that end up in the unit, well, one step back. So I think the other interesting thing about this disease is how incredibly sick these patients are. So even for a place like hospital center, which is used to taking care of very, very, very ill patients, we have very sick patients on the floor. And so if you're ending up in the ICU, you're multiple standard deviations above your, you know, even the typical illness severity that we see. So most of the patients end up to me, I'm putting them on high flow pretty early, unless they need sort of a rapid intubation for the reasons we just discussed, you know, 5 minutes ago. So, I mean, I try them on high flow, and then I try the rescue strategies that you know, we think could work in terms of trying to have them self-prone. You know, some people have sort of messed around with EPO through the high flow. I'm not sure how efficacious that is, but incentive spirometry, and I really try and head them off from the intubation because, one, it's risky for us. Two, I think it's risky for the patients just from, if you just look at data, right? And if you can ride them through on high flow, then I think there's huge value there. And we've done that. I mean, I've certainly had patients that I think were, on the precipice and probably would have been intubated in a lot of other circumstances that we really did our best to avoid it. And they sort of came through it without ever being on the vent, didn't really have the organ dysfunction that we're seeing. So I don't know if that was the disease or if that was their, I don't know if that was partly that we didn't put them on the mechanical ventilation or if that was just the disease process as it was going to go no matter what. I will say that some of the things markers I've seen that, portend badness is obviously older age, obesity. And then as you start to add on every sort of comorbidity, the typical ones, diabetes, hypertension, you're almost creating your own COVID severity score, which is, I really think it's age, obesity, and then comorbidities. And once you start combining those, the likelihood that the person is going to sort of only require supplemental oxygen through some non-invasive device, I think diminishes. So that's my thought. I think high flow is a great tool. The other thing about high flow is, in a lot of ways, it probably minimizes aerosolization in some ways, especially when you compare it to, nasal cannula alone. So I think that there is some value to that as well. You get some humidification, you get a little bit of PEEP, you get good flow. So I think it makes people feel a little bit more comfortable, and you can deliver high FiO2. So I think it is a very ideal mode of delivery.
John, just a quick comment on that. I agree with everything that Shane said. I think one thing we have to be cautious of is, like Shane mentioned, like a COVID score, which I agree with. We have to be careful about using those data to decide what we're going to do with the person in front of us. So, for instance, allowing, say, diabetes or obesity or age to be something that guides our intervention. Yes, the person may do worse, doesn't mean I should intubate that person now. And if that makes sense, because we don't know if these things are just associations, and I think we have to be cautious about allowing it to gauge our decision making.
Can I just add one more thing? I think everything that Shane said is perfect. I tend to think that we do damage with the ventilator. It just seems that, you don't see any of the other organ failure until you put them on the vent. And again, we're not sure if that's because that's just a marker of how sick they are, but we've intubated them at many different times in their disease process. When we first started managing these patients, we intubated them very early on, and they had no other organ failure. And you put them on the vent, and all of a sudden everything starts failing. And we've waited much longer now, and the same kind of pattern happens. The only other thing I would add is we have to shift kind of some of the ideals or the standards that we typically thought of as markers to intubate patients. The two biggest ones are the respiratory rate and the hypoxemia. We would never let someone breathe at 30 and sat at 88% on max high flow settings before. That person would just get intubated. But nowadays, in this disease process, there's more and more evidence and more experience saying that you can probably let some of those patients ride as long as they're awake, alert, and talking to you and don't have the signs of respiratory fatigue.
Yeah, and I just add briefly, I agree with, like Manisha's point is great. And that's why I said you really have to use your clinical skills in this, I think, more than anything else, because there's not a formula we can follow, and there's not a cookbook that we can say. And there really probably is. It's right. We don't know if this is just signal or noise, the stuff that, we see, because we just don't have enough data on it. So yeah, I mean, I think you have to approach every patient individually and just use, sort of the best experience that you're gaining from, sort of forums like this. I also do agree with Rory is, if you ask me personally, it seems like mechanical ventilation is not helping people. Some people it's unavoidable, right? But there's a very natural progression of this. They get intubated, then they go into some shock that is sort of this like cryptogenic shock that's not really clear really truly what it is. I mean, it's probably mostly distributive component. And then their organs start to fail, and the amount of, acute kidney injury and acute kidney failure is way higher than you would, typically see for our, severe pneumonia requiring mechanical ventilation. So So yeah, I agree with both those sentiments. And again, just I think there's a whole thing of saying learn as much as you can on this, but approach this individually with a lot of humility and recognize there's no absolute right answer.
And then the last thing is we would never take any other disease process. Like someone comes in with a pneumococcal pneumonia and we're on 6 liters of nasal cannula, and then we say, okay, let's intubate them. Like there is some kind of shared experience that we have a lot of other tools that we should be using to treat respiratory failure, and we should use them in this disease as well.
Jon, can I propose a hypothesis and ask my colleagues that all attend in the ICU for their thoughts on this? Because I think there's what I've been starting to extract charts as part of a system-wide COVID database. And both in terms of what I see in some of the initial settings that we have, as well as feedback that I've gotten from the research resident, what I wonder about is if we are kind of putting together things in a way that may be injurious. Maybe it's not the vent itself, but maybe it's the constellation of care around the vent. And what I mean by that is, early on we were told, don't give a lot of fluid, right? So we see these patients that come in that have probably been ill for several days, that have increased insensible losses, decreased PO intake, and I would contend are probably overall hypovolemic. And we thought early that maybe this is like ARDS. And so we're intubating hypovolemic people, shifting them to this very high intrathoracic pressure, exposing them to high PEEPs because we see this profound hypoxemia, and we've always associated profound hypoxemia with shunt with increased mean airway pressures to try to recruit. And so now we have hypovolemic individuals who get exposed to high intrathoracic pressure and go into shock. And we were taking these people who have minute ventilations of 20 liters pre-intubation and putting them on 400 or 500 mLs of tidal volume and a respiratory rate of 16. And so we're exposing these people, and particularly if we use rocuronium, where they can't compensate for the profoundly low minute ventilations we put people on. So we're taking individuals that are hypovolemic, exposing them to high intrathoracic pressure, not volume loading them, and making them unable to compensate for the metabolic acidosis. And I think that some of that is leading to some of the downstream organ failure that we're seeing, but I'm not sure. And I think that there's also been some modification for those things. Maybe we're using more fluid, maybe we're using lower PEEPs, maybe we're not using as much rocuronium, but I'm wondering from my ICU colleagues that attend in the ICU, are you seeing any differences, or are you seeing any patterns that would suggest that any of that might be true?
So from my perspective, I think a lot of that is a possibility. I certainly think that our tendency to tie FiO2 to PEEP, and our group, when we initially were preparing for this, recommended using the ARDS-NET PEEP table, right? So as you go up on FiO2, you also go up on PEEP, which I think is now a huge mistake. I think given this disease and the fact that they don't have a lot of shunt fraction going on, you have to uncouple your PEEP from your FiO2, and you titrate your FiO2 to oxygen sat, and you titrate your PEEP to the actual compliance of the patient's lung. I also agree that I've become more liberal with fluid. I think they are fluid down. I'm not sure fluid actually corrects the AKI and renal failure. I've never actually seen it work. But as you load them with fluid, basically it all starts the same way. Like Shane said, they get intubated, they go on pressors that first night, and then the next day they just stop peeing. And we say that they're fluid down, and we fluid load them, and I have yet to see it actually fix the problem. But they do seem to not be, I have not yet found one, and I've done a lot of ultrasounds on these patients that are volume overloaded. So I do think they are fluid down. Whether that's going to help their organ failure, I'm not sure.
Yeah, I agree with that. I don't know what the right answer is. I mean, you also sort of pick your poison a little bit too. I don't think ultimately that that fluid downstream is helping their lungs. I still think there is probably a leaky component to this. And I personally, I also think this is just like a demon virus, and it essentially. It just is. I think there is a lot of this. People love it. Once you start hearing someone use the word cytokines, they're about to give you some BS. But I think there probably is an inflammatory cytokine component to this. That the body's just in this diffuse inflammatory process, and that's why I'm not sure if if maybe the intubation part is just a marker of this crescendo of inflammation that's going on, and you're seeing it in the lungs externally, and then, in the next 24 hours, you're seeing it in the kidneys through biomarker, So I don't know. I think the real answer is probably all of it. I think, there probably are a little fluid down. I don't think the extra intrathoracic pressure is necessarily helping them early on. And then I also think there's probably a huge inflammatory cascade that is driving a lot of this. Jen, I don't know. Do you have anything that you sort of saw? I know you've been taking care of a lot of the ECMO patients.
I agree with both of what everyone said so far. I think initially in the early course for these patients, it's okay to be a little bit more liberal with fluids. And when I say early course, I mean the first few hours, like maybe the first day or two. But once they get to hospital day 7 or 8 and they're in the ICU, liberal use of fluids is not going to help anybody's lungs at this point. And we know that I think increases mortality for all of our patients, but I also don't diurese these patients. I think the PEEP we're learning a lot about as we're taking care of these patients as they progress in their disease state, that we were over-distending a lot of them and actually seeing worsening hypoxemia with higher PEEP. And now we've been doing more calculated, individualized, ventilation support for them, and also oxygenation support on the ventilators based on kind of what their compliance looks like, what their gases look like on a day-to-day basis. So it's still very humbling, and we just kind of take it day by day, but I don't have a cookbook, one size fits all for all these patients.
Yeah, and I'll just add to the fluid status thing too. I had a cohort of patients that, were on CRRT just because, they went into, renal insufficiency. And, this is obviously later in the course, past week 1, or, towards the end of week 1, where I pulled a lot of fluid and was able to get improvement in sort of their oxygenation, and able to unprone them and actually able to extubate them. So again, I don't know. The real answer is probably there's different times for different things, and I think if you want a takeaway for it, it probably is you don't have to be super fluid restrictive early on. Don't go cowboy and start giving them 8 liters of fluid. That's not going to help. But I think there probably is a little bit for more fluid liberal within reasonable amounts early on, and then like anything else, as you get longer in this course, drying the lungs out as much as possible probably has a role as well. And I let them auto-regulate too. For the ones not on CRT, I tell you, I didn't do a lot of necessarily diuresis. I saw some diminishing returns on that. So did a lot of auto-regulation in the middle part there.
It's a great conversation, and there's no question that this illness has really challenged conventional dogma in so many ways. And just to see the arc of our understanding, or what we think we understand of this disease over the last month, is absolutely incredible to see how we marched into this pandemic with what we thought we would see, and based on what we heard from worldwide experiences, and what we're actually seeing in our patients in this region is actually vastly different. So talking about challenging conventional dogma, I want to transition into D-dimers and anticoagulation. And I know this has been an absolutely hot topic. We've all seen sort of like the routine bundle of labs that are ordered on our persons of under investigation, suspected COVID illness, but we don't have a positive COVID test yet. They're sick enough, they're probably going to get admitted. We want to get the right labs for the admission team, and kind of anticipating what will be wanted. Ferritin D-Dimer, surprise, D-Dimer comes back at 10. So all of a sudden we have a patient who is tachypnic, they're tachycardic, they're hypoxic. Clinically, we think they have COVID, but now we have a D-Dimer that we really don't know what to do with that result. Oh, and by the way, the pathophysiology of COVID illness includes thrombophilia, where they're at risk for clotting. So is this the COVID illness? Is this a PE? Is this both? Is this neither? So thoughts from the panel, and I know our EM critical care and hospitalist working group has spent a lot of time discussing anticoagulation. What are the lessons learned? What are the best practices? who should we be CTing, who should we be anticoagulating, who should we just attribute it to the underlying inflammation and laying down a fibrin and breakage of fibrin that's occurring with the pathophysiology.
Rory, what do you? So Rory and I are both on the working anticoagulation working group. So
it's been a lot of Zoom meetings.
Yeah, lots of Zoom meetings. So, I don't. Do you want to? Well, so I'll lead off with saying that probably early next week you will see MedStar messaging about an anticoagulation protocol that is going to essentially have three categories like this: high risk or confirmed, which is essentially what we're typical, right? So it's like a confirmed VTE. It'll have very similar anticoagulation, and then there'll also be sort of the prophylactic component, which is the third category. The one that is like sort of the additive and the most controversial, and sort of as we're learning more experience with this, is this intermediate risk group, which will give clinicians options to anticoagulate if they think, not proven, but there's concern for VTE or severe hypercoagulability. It'll give clinicians options to anticoagulate. So that should be out within probably 5 to 6 days. And it's going to generally look like that, 3 different categories. The main one that's going to be different for us is going to be that intermediate categorization where we'll give you some anticoagulation options.
Jon, maybe I could talk a little bit too. As you know, I'm not a critical care doctor. I'm just an emergency physician. But the biggest question for me when I was looking at these guidelines is, how do I tell emergency physicians how to evaluate patients in the respect of anticoagulation? And one of the things we've seen throughout the system is a broad range of D-dimers, anywhere from 0.6 to 23. And that number isn't necessarily predictive of who has a PE or a DVT. And so one of the things that I've noticed in emergency rooms throughout our system is that there are patients who go home and then they come back, right? Because maybe they're still short of breath, or they feel a little worse, or they have chest pain. And I found that sometimes checking those markers can be helpful, because you can trend their inflammatory markers and perhaps find something that you wouldn't have found otherwise. And I think that having a set of guidelines that we know will change as we get more information is at least helpful to sort of let you know parameters to start anticoagulating these patients.
It's just tough because there's 2 different questions you're asking. One is do we need to have a higher clinical suspicion to actually work patients up for venous thromboembolism in general, patients with COVID? And the answer is probably yes. It is a hypercoagulable disease, and they're more likely to have VTEs. I think the D-dimer becomes even more useless in this disease process than in typical patients. I don't think it helps us from that standpoint. I think you still have to make a clinical decision on who you're going to work up early, which is the same difficult clinical decision that we normally have. And then the next question is, do these patients, so the COVID patients, benefit from anticoagulation or a more aggressive anticoagulation, whether they have macrothrombi or not? I think many of us working in the ICU will tell you there's this phenotype of patients that clot everything. They clot their lines, they clot their CRT circuits, they clot their ECMO circuits. When you get TEGs, they are massively hypercoagulable. And the question there is, would they actually benefit from more aggressive coagulation strategies, whether or not they have macrothrombi or not? And those 2 questions are what we've been struggling with our anticoagulation protocols. I don't think we have a great answer yet. I think
you can see it in the guidelines, right? Because this is still going to be individual clinician decisions, right? There's not enough evidence out there to say, okay, yeah, we should anticoagulate all these people. Now, some centers are going that direction. A lot of centers are trying to take the middle ground, which is saying, like everything else, you have to add in some clinical, data and gestalt to this. Like certainly if you have these lines that are clotting, the CRT lines, then maybe that's an indication for anticoagulation, where sometimes maybe you wouldn't do that. You would you'd watch it a little bit and say, I'm just going to change my prescription for the CRT machine. But now, it's that, well, if they're clotting there's probably some clotting elsewhere. But we don't have a blanket approach yet to say every patient who has COVID needs anticoagulation. Because there's obviously risk with anticoagulation too. And, again, people who I think are bedside with these patients are seeing massive, again, multiple standard deviations above normal in terms of hypercoagulability and clotting. But, does that translate to anticoagulation improving patient outcomes? And we don't have the data for that yet.
Yeah, I think one of the things, how this will interact with the emergency department is probably less of that middle group where we as emergency physicians should be anticoagulating people that we just, think are in this hypercoagulable state. And I think the two places that it probably becomes more important for us is one, the identifying the patients that do have VTEs. And that is the same difficult process we normally do. And then the other one is probably actually on these patients starting prophylaxis to the ones who are getting admitted to the hospital, especially as we board more and more of them in the ED, as the hospital fills up. Getting that in early is probably something that we can do to help.
Yeah, I totally agree with that. I think that a lot of this, a lot of these are probably going to be decisions that are going to have to be wrestled with, inpatient once they're admitted. But I think there is potential value in you getting that prophylactic dosing early. I mean, honestly, the TANG study was some of the controversy around that is it showed, anticoagulating in the patients in cohort in China improved outcomes, but really it was prophylaxis dosing of it, because they don't typically give prophylaxis to their patient population because it's a different genotype. And so that's a little controversy saying, well, anticoagulation helped. It's like, well, it was prophylactic dosing. But again, they don't use prophylactic dosing normally. So, does our patient population need more intermediate therapeutic dosing above the prophylactic? But I think if you take all that away, the one thing you can say for sure is that prophylactic dosing did seem to have a signal of helping. And so getting it in early, it's probably not going to hurt any of, if you have to go to more intermediate or therapeutic dosing, it's not going to hurt to have that prophylactic dosing on board. Again, especially if there's anybody that's sort of lingering in the emergency department in terms of boarding.
And I think one of the things, getting to the kind of the multifaceted question that Rory was talking about, we're talking about CT imaging or not, and what to do with an abnormal D-dimer, and then we're talking about anticoagulation and sort of risk stratification. I can tell you that just from the forward-facing ER vantage point, as all of us know, is that we typically utilize that D-dimer for its negative predictive value, right? We're so-called rolling the D-dimer dice, and if it's negative, we're okay, right? Because the chances of it being a venous thromboembolic disease is that much lower. But in the case of COVID illness, the level of baseline D-dimer abnormality seems to be higher, but then again, we only know what we know, and we don't know what we don't know. And I guess the real question for us is, and where we really need data and studies to look at this is, how many of these patients where we're seeing D-dimers and we attribute it to COVID illness is actually venous thromboembolic disease that's worthy of treatment. And I guess that's the real question that's out there that none of us have an answer to, but it certainly makes it challenging in trying to make our prospective clinical decisions on what to do with imaging.
Yeah, I would just add, I don't think you can use the D-dimer in a retrospective fashion here, saying someone ordered the D-dimer, it happened to be positive, now I have to go back and decide whether this represents a VTE or not. I think you have to ask that question before you order the D-dimer or before you get it back, meaning, do I think this person has a PE? And if the D-dimer is negative, I can then no longer go farther. But if it's positive, I have to continue my workup. But,
I think more broadly, I think you can't apply our old paradigm of how we approach D-dimers. I mean, to me, that's the best I can say, is that you can't use the paradigm we used to use for D-dimer in this disease process. So really, it's like we're saying for every other thing, right? We can't use our paradigm of mechanical ventilation, our evaluation for who needs advanced, support. all these things, we can't use the old paradigm. I think it applies to this too. So you go back to, you really, I think at this point, it's clinical gestalt, you know, and weighing the risks and benefits of, staff, exposing staff, and using very precious resources like, CT scanners that need to be sort of essentially terminally cleaned in some fashion. So I think the first thing you gotta do is disassociate your typical approach to how you use D-dimers 6 months ago. I just don't think.
I think even back in the day when you were using D-dimers and using all these rules, there was always the thought that your clinical gestalt was just as good as a lot of these rules are. And so you really need to get back into that feeling of, I'm looking at this patient, I'm watching how they're breathing, I'm putting it all together with their risk factors, their oxygenation, what they look like, and maybe they're a repeat person or not. And then you just need to make a clinical decision right now because we just don't have the data. And I think Manish, kind of working on making a registry and looking at this, hopefully will help us in the future and getting more studies going.
Yeah, I think one of our challenges is if for any retrospective database data collection, we're not going to have data on all of the patients getting an ultrasound or a CT, right? It's just going to be those who are clinically significant enough where there was enough concern. It does make me wonder if we should be doing more point of care ultrasound to look at people's lower extremities.
And one of the, I've always kind of utilized the point that the best way to exclude a PE is to include a diagnosis that's not a PE, the compelling alternate diagnosis. But it just so happens that the compelling alternate diagnosis of COVID may very well lead to the diagnosis that you're trying to exclude by having that compelling alternate diagnosis. So speaking of conventional dogma and standard dogma, a great question came in regarding lactate. So another laboratory test where we have tachypnic, tachycardic, hypotensive patients that come in, they get a lactate order, a lactate is resulted. What do we do with those results? How do we manage fluid in the setting of COVID-19?
Can I take this one? This is my soapbox.
Yeah.
So, I mean, I would argue that we mismanage or misuse lactate way before COVID came in, and the way we use lactate as a surrogate for should we give someone fluid or not, and we use it as a yes, no. Lactate's elevated, give them fluid. Lactate's not elevated, they don't need fluid, and that is empirically completely wrong. Most lactate we saw even before COVID. So in sepsis, let's say, most of the elevated lactate we see has nothing to do with end organ hypoperfusion and hypoxemia or hypoxia to the organs. It had to do with the sympathetic drive that was going on to fight the infection. There's reasonably good data that has no correlation with fluid responsiveness. And you have one randomized controlled trial, the hydrometer shock trial, showing that when you use a lactate approach to resuscitate septic patients versus an alternative approach, you actually have worse outcomes. So I think our current practice of lactate way before COVID was probably unwise. In the COVID era, I would say you have to completely think that lactate and the has nothing to do with end organ malperfusion. Most of these patients are not in shock when they come in. In fact, we don't typically see the shock until after they're intubated when they go into the multi-organ failure. I would say if you see shock in someone that you think has COVID, you definitely want to figure out why they have shock and think about a PE or think about other causes, because the normal phenotype we're seeing, they don't have shock, they don't have hypotension, and most of their elevated lactate is probably related to, one, their work of breathing, so the diaphragmatic work of breathing, and then two, the sympathetic drive or response to the illness itself. So definitely in these patients, dissociate your lactate from your fluid. That doesn't mean don't give fluid, just use your clinical assessment or ultrasound or other things to actually determine where you think their fluid status is.
And I think the point that was made earlier regarding the insensible losses, I mean, conventional wisdom is if someone is breathing rapidly at home, there has to be a considerable amount of insensible losses. But at the same token, we don't want to kind of overshoot that mark and just trying to right size it and really finding titrating everything to what you're seeing in front of you. And that's, I think, if I could encapsulate one message, which is kind of like the non-answer, right? It's like, well, just treat the patient in front of you. But that is the answer, because we're challenging, our dogma in so many ways with this illness, and we continue to learn. So we'll go ahead and wrap up the panel discussion at this point. Greatly appreciative, Manish and Rory and Carrie and Shane and Jennifer, you who joined us, and rich discussion. We'll certainly post this on our MEP YouTube channel as well. Hope everyone stays safe, be well, keep healthy, and we'll look forward to providing more updates in the next week. Thanks, everyone.
Thanks.
Thanks, John.